Please welcome our panel. The future of healthcare AI depends on data with Sina Bari from iMerit, Bobby Anderson from GE Healthcare, Daniel Chow from UC Irvine, and Naqi Khan from Microsoft.
Welcome back, everyone. I'm Dr. Sina Bari, Director of Medical AI at iMerit. I'm very excited to bring you this panel full of clinicians and innovators working in the healthcare AI space. Let's start with introductions. Bobby?
Hi, my name is Bobby Anderson. I am a clinical insights leader for point-of-care ultrasound at GE Healthcare.
Terrific. Welcome, Bobby. Naqi?
I'm Naqi Khan. I'm a principal program manager with Microsoft Health AI. By background, I'm a physician and an informaticist.
Wonderful. Thanks for being here, Naqi. And Dan?
Hi, my name is Daniel Chow. I'm an assistant professor at the University of California, Irvine, where I co-direct the Center for Artificial Intelligence and Diagnostic Medicine. I also lead the neuroimaging division as a radiologist.
Terrific. We have a great group here, both from the clinical side as well as working in industry. Let's jump into some questions. AI is obviously a journey. Where is healthcare in that journey, if you think of it from infancy to widespread implementation? Where do you think healthcare is with regards to adoption? Let's start with you, Naqi.
Yeah, I think we're at this final critical mass juncture, where it's really feeling like every CMIO that you speak to, CTO that you speak to, is so keenly aware of wanting to implement some form of AI. They might not know what that fully means or how that will look like across the organization. But as we've had these engagements, they want some pieces of this because they've seen it work so well across other industries. So I think it's really a ripe time, and I think different industry partners and organizations are making a lot of headway and making it a lot easier to implement these types of technologies.
And interesting. Bobby, what's your impression working with GE?
Yeah, so in the world of ultrasound, AI is still very much in its infancy, especially in adoption rate. So it requires a large amount of real-time data, and we're also still at the mercy of computing power. We're waiting for new processors to come out that allow us to use more of this data and to perform these AI measurements and tools in real time.
Thanks. And Dan, I know you wear many hats, both as a clinician, as a part of academia, and also participating in industry. What's your impression?
It's very heterogeneous. And I think part of what people forget is that healthcare industry is very, very broad. Certainly in some things like process automation, billing, workplace efficiencies, I think you're seeing much more quicker adoption of AI. But in things such as like diagnostic tools, real-time detection, even triage or disease prediction, I think that's where it's still in its infancy. We're certainly seeing some tools come live. Our hospital has a few tools that are live right now. But I think people forget that healthcare spans multiple different disciplines. So in some areas it's faster, in some areas it's just starting to online.
Absolutely. Staying with you, Dan, do you see it affecting patient outcomes?
So I think that's a hard question, and I think that's probably the most important question. A lot of these tools, when you look at when they're getting their FDA clearance, is about what is their efficacy or specificity. But what a lot of tools have not done a convincing job yet is showing that their tool actually results in improved clinical outcomes. So I'll give an example. I'm a neuroradiologist. A common tool we have is for diagnosing hemorrhages. So we've actually demonstrated that we can diagnose strokes, hemorrhages in near real time. But before that, we were at about 20 minutes. What does that 20% gain result in? Does it actually result in improved patient care, reduced length of stay, mortality, morbidity? Those studies haven't been done yet, and that's just one example. So I do think that these tools are serving their intended use, but whether they're actually affecting patient outcomes, I think the jury is still out.
Yeah, I want to wholeheartedly agree with that statement that it's hard to pin down that causality. It feels like something good is happening. So I think similarly with advanced decision support within the clinical realm that leverages pieces of AI, we can do things like provide an intervention sooner or provide recommendations for, say, genome screening sooner. and those types of things help potentially get patients treatment sooner, hopefully. But again, as was pointed out, it can be challenging to actually connect the dots and show that this was truly a great patient outcome.
Yeah, I agree with both of you. It's really important to prove positive patient outcomes. We have several studies that are currently in progress, but the systems that we work on are made for physicians to use and not ultrasound techs who are normally more trained. And so these systems go into an emergency department. And in the case of undifferentiated shock, for example, the amount of time that it would take to order a bunch of exams and labs and wait for that to come back could be way too much time when a patient is in the active process of dying. So we have made tools that will help doctors in that moment to make a quick diagnosis and to alter that patient's care. But I do agree that it's very important that we continue to look for studies that prove this positive patient outcome.
Yeah, I think those are all really valuable insights. Staying with you, Bobby, I know you work on the development side. What challenges do you face, specifically with data operations, working with ultrasound?
Yeah, so one of the challenges, of course, is data. We need large amounts of data, and then also just in healthcare in general, we're looking at a worldwide shortage of doctors and aging population. Ultrasound specifically requires a lot of experience and expertise, which is a barrier to entry for physicians who don't know how to use the technology. So I think that's where AI has a huge opportunity to increase adoption rates of use of ultrasound and other diagnostic devices among doctors, nurses, nurse practitioners, and even EMTs.
Yeah, I remember ultrasound being talked of as part of the routine physical exam in its evolution. It's that powerful of a tool. Naqi, same question to you. Where are the challenges? Where are the opportunities?
Yeah, data is such a sticking point, definitely for us. It's as soon as we start talking about machine learning in any kind of form, we want data that's annotated. We want data that's been labeled. We need people to be able to help label this data for us. And we're so nascent in the tooling that helps these individuals label this data so that we can build models potentially. So again, I think really echoing Bobby's sentiment that without data that's correctly cleaned and also considered well. So a lot of AI is thinking about responsible AI and making sure AI is ethical. So as we create models for particular populations, we need to think about like how they might affect a population that might be totally different than the one where I've been, originally based.
Absolutely, I think that's really an important point, that it's services, it's people, and tools and software. Dan, what's your experience in terms of opportunities and obstacles? Please.
I'm going to build on what Bobby and Naqi said, and I think a lot of programs have figured out the volume issue. I think what we're not doing a good job is with the curation. I'll give it a recent example of COVID, and I'll give two examples. So one example, for example, is how do we define asymptomatic patients? What we identified is when you have the NLP do it, it's a different definition. When you have an ER doctor do it, it's a different definition. But when you have the ID specialist, they have different definitions. And that changes the narrative based on the asymptomatic rate. And so we're finding it's not just having curation, but having the domain experts actually label the data well. You think about cancer, if you label the progression of disease differently, you could inadvertently label ineffective drugs as effective and effective drugs as ineffective. To Naki's point about populations, we took a COVID calculator from overseas and we tried to apply it for our population, and we quickly observed it broke down. And when we looked at the inputs, because overseas one of their risk factors was anorexia, whereas for us one of our risk factors is obesity. So does the data actually match the population? Is the data actually labeled well? I think are all significant issues that we're tackling with.
Terrific. Given this breadth of knowledge, of domain knowledge, and the depth of domain knowledge, how does AI bridge that gap? Are there any successful strategies that you've found? Naqi, let's start with you.
Yeah, I think for our team and how our organization has been successful and I think this comes back to the previous points of understanding not only the populations but the people involved, as part of the organization. Until we sit down and understand the user's journey, as to how they want to use a tool. Like once we start to understand that, then we can start to think about how does AI fit here? How does machine learning fit here? Because there may just be some easier tool that doesn't involve all this kind of fancy stuff that also achieves the end outcome, which again, hopefully is an improved patient outcome. So we do a lot of code design, a lot of code development, trying to really engage, trying to really, use some product management, principles as we build out wherever we're trying to build out. But also, I think not losing sight of what we're effectively trying to do. Like everyone talks about affecting the quadruple aim, this like sense of like, trying to improve patient lives, but also clinician lives. So is this thing that we're creating going to have an impact on quadruple aim in some kind of way? And if the answer is yes, then it's likely that we will want to double down on that.
Bobby, your thoughts?
Yeah, to jump on that, the user's journey, I like that term. That's something that we care about a lot, and we've put together teams within our portion of GE Ultrasound, which combine data scientists with physicians and with ultrasound technicians. So that way we've got within our teams, while we're developing these tools, input every step of the way from users that will be ultimately the end users of this. And then, we also try to get our data scientists and our engineers connected out in the world so that they can go and do visits and they can watch how these tools are used. And they're not just programming something that they don't know the impact of, and they can go and see how what they're doing can impact and how it can save a life.
Dan, do you see resistance among clinicians to use these tools?
Yes and no. I think that's the reason what Naqi said and what Bobby said is so important, is to involve clinicians at the very beginning at ideation. And as opposed to me saying, or as the developer saying, like, hey, I have a cool tool or I have a cool process, we want to use it. I think it's more important when we go to clinicians and ask them, what are your problems? What are things that we can solve on? How do you think that we can do this to improve things together? I think once you have physicians who are more bought in and who are actually part of that development, you're more likely to gain some level of engagement. That's something that we've seen. And I think it's really important that it shouldn't be a back and forth transaction, but it really needs to be a team effort where, like what Naqi was saying, co-development has to happen along every step. When we're looking at the data, it's not just a data scientist looking at it, they're looking at it with a clinician and being like, hey, we're seeing this abnormality, or what does this lab mean? It's very easy for a clinician to say that, we don't really look at these labs. The most important lab that I look at is here, and you'll find it in this flow sheet, and you should do this. Or a lot of times clinicians will have these insights and say, what we've been seeing this, can we do this kind of analysis with what you have? It's when you start having those team efforts with multiple domain experts, that's when you have a lot of fun.
Absolutely. I think of it from my own clinical practice. When you're using tools, you just want them to work. But in development, we know that process is often iterative. And so, how Naqi, wearing both hats as you do, how do you tackle that challenge?
Yeah, I think, and coming back to several points from before, we spend a lot of time on this idea of like being transparent and having that human in the loop whenever possible. So not only on the development side, but as we create these tools, is there something that we can surface to the clinician to help them rationalize what they're seeing? So you may just get like, hey, end result, go do this. But if we can provide some kind of rationale as part of our platform, that seems to provide a significant amount of at least credence that I can trust this, or this came from this note, or this came from this flow sheet. At least I can then go back and, somewhat quell my skepticism about it. So I know transparency in AI and that black box explainability is like all kind of, I think, cutting edge topic. I think maybe some skepticism on it in terms of like, is this too much? Now I need to evaluate whether the rationale is correct. But I think we're moving in the right direction of like trying to build trust, and also just, again, being very open about the metrics involved, the patients that were part of the training that led to this AI system.
Yeah, I agree. I think the aspect of trust is really important when we're talking about AI tools. We're asking physicians to put their trust in the hands of an automated tool that we've designed for them. So we often have to prove our validation and verification along the way. But once they do use it and believe in it, then I think we're seeing a large adoption of users who will use the tool and trust the tool, and especially younger, newer physicians that are right out of school, they are gravitating towards AI.
So I agree with all that. I have a fun story for Naqi. I remember we had, there was a pneumothorax tool. Pneumothorax is when you have airs in the lungs, and there's an AI tool that was trying to identify the pneumothorax. And then when they're looking back at what was being identified, it wasn't identifying the pneumothorax, it was identifying the chest tube. And so it wasn't really, and that's, I think, goes to your point of explainability. Now, to Bobby's point, this is actually a challenge that I face as an educator at a med school. And that is, when do you introduce these tools to trainees? So I think I'm still old enough to know what a Thomas guide is, but if I ask any of my students to go map from their house to the hospital, some of them wouldn't be able to do that without Google Maps. We kind of joke about the lost art of reading a map, but are we ever going to have a situation on the last art for how to identify subtle strokes or aneurysms or things like that? And so we actually have a study now where we're looking at trainees of different levels and seeing, when we expose them to AI or tell them that not AI is involved, and see what is their variation in their confidence, what is their variation in how fast they work, but also what is their accuracy. My concern is that if we give these tools to trainees and are so used to just becoming over reliant on these tools that they may overly trust these tools and not be able to make their own decisions. So it's a very fascinating topic right now.
Yeah, and I think when we look forward, I'm curious. Oftentimes when we're caught up in the things about AI that are truly exciting and maybe part hype, but also truly transformational. What excites you, and maybe also I think what you're speaking to, Dan. What do we fear? What loss of the art of medicine? I mean, is I think a really pertinent one.
Yeah, I totally agree.
But the flip side of that, in 5 years, are there AI technologies that you see on the horizon that you're excited about?
I don't know if it's so much the AI technologies, but so much the orchestration of different data sets now. So one of the things that has been really getting much more headway is precision medicine being driven by AI. So now you have historically multiple complex data streams, from omic data to EHR data, all the way to socioeconomic determinants. Before, it was really difficult to map all these things together. And there's a big belief now that with AI, we are going to be able to integrate multiple different types of data sets to better represent our patients, to make better predictions, and to really guide care. Personally, that's what I'm excited for.
Yeah, absolutely. I think, as the panel topic mentions, the future depends on the data. Bobby, your thoughts?
Yeah, so I think, like I said, we're still in the infancy here with specifically with point of care ultrasound. Our GE Venue products that we have were the first family of ultrasound products to feature AI, and since then there have been a lot of other ultrasound companies that have come out with their own tools. So we're starting to see a lot more from the vendor side as putting these tools out there. So I think in the next 5 years, we'd see a lot more AI tools coming out from different companies, a higher adoption rate, and I think really we're looking at more of the 10 to 20 year time frame to where we'll get to a point where AI is used in every ultrasound exam.
Absolutely, yeah, and I think my impression is that the digital radiology space, being sort of incumbently digital, is the most mature, one of the more mature spaces. Naqi, well, what's on the horizon that you're seeing?
I think for me, it's all about augmentation. I think one of the concerns in the past has been, are we replacing clinicians? And connecting back to the previous topic, for me, I think we're really releasing tools nowadays that let clinicians hopefully perform their work better and more accurately, and at the same time, not have to take on as much of the administrative burden that's traditionally cause clinicians to burn out or get very frustrated with their roles. We have teams now looking at how do we leverage just voice technology to make it so that you no longer have to write a clinical note. If that's something that we can achieve in the next 5 years, I feel that would be so significant in terms of clinicians feeling like they can get back to treating patients.
Absolutely, and I think every advancement comes with some fear that we're losing something, and I think it's important to be mindful of. But we have adapted and grown in the past. That's about all the time we have. Again, thanks to Dan, Bobby, Naqi for a terrific panel.